Good day. My name is Stacey Reason, and I'm going to share with you the clinical practice guidelines for GSD 5 and 7. For those of you that don't know me, I am one of the founders of IamGSD, the International Association for Muscle Glycogen Storage Disease. Clinical practice guidelines essentially bridge the gap between health policy, best practice, local context, so what's happening in each country, and patient choice or patient preference. There are a number of different definitions of CPGs in the literature, but the Institute of Medicine defines them as statements that include recommendations intended to optimize patient care that is informed by a systematic review of evidence and an assessment of benefits and harms of alternative care options. Or more simply put, clinical practice guidelines are a way of packaging evidence and presenting recommendations to healthcare decision makers and healthcare providers. Back in 2019 at the AGSD conference in Houston, the Scientific Advisory Board indicated that they really wanted to move forward with clinical practice guidelines or CPGs for GSD 5 and 7. It was at that time that I offered on behalf of IamGSD to help coordinate this effort. We put together an international team. There are 7 countries represented and 13 clinicians and researchers, along with myself and Andrew Wakelin, that bring forward the patient perspective. We also established an external review team of 3 members, Priya Kishnani, Mark Tarnopolsky, and Pascal Laferret. What I will do at this point is provide an overview of the CPGs for GSD 5 and 7. Please keep in mind that there might be some small changes, as at the time of recording in July of 2021, this manuscript still has to go through the external review team, and therefore there may be a few changes forthcoming. So we begin the CPGs to discuss the purpose. Why did we do this? Essentially, we developed these clinical practice guidelines to serve as a resource for clinicians and patients. We hope that these CPGs will decrease variation in clinical practice, as we have heard from patients that they are offered different recommendations across the globe, and ultimately to improve the quality of care for those who are affected. The next section looks at a general background for GSD 5 and 7. We begin with an overview of the pathophysiology. We move on to a history, who discovered each disorder and when. We provide nomenclature, so how are these GSDs referred to in the literature. We talk about the clinical overview, the signs and symptoms, both objective and subjective. Clinical variability. As you know, in GSD 5 in particular, there is heterogeneity in the clinical manifestation. And then we look at epidemiology. Under the methods and process, we talk about how we went about developing the clinical practice guidelines. Where the current evidence base was insufficient, expert opinion and consensus was applied. We then outline who the target audience for these CPGs are, beyond, of course, the obvious, the patient, their family members, and neuromuscular specialists. We also do target a number of different specialties, as the overall impact of GSD 5 and 7 can be nuanced, resulting in a cascading effect on multiple systems. The next section moves on to diagnoses. We begin with differential diagnoses, and the hope is to be able to lower the age of diagnosis, as there currently is a median diagnostic delay of approximately 29 years for GSD 5. I do have a differential diagnosis flowchart, which is on the next slide that I will show everybody. We then talk about misdiagnoses. Again, there's quite a bit of information for GSD-5, but 90% of people with GSD-5 have received a misdiagnosis prior to receiving a corrected diagnosis. That came out of a 2017 paper by Skelko. The hope is that if we can outline what some of the more common misdiagnoses are, future patients won't have to go through that and can receive a corrected diagnosis at an earlier age, and therefore implement best treatment at an earlier age. We then move on to genetics and talk about the different pathologic variants for each of the GSDs. Muscle biopsy certainly is or can be used as a diagnostic tool, particularly where variants of unknown significance are found. And then lastly, in GSD-5, second wind also can be a diagnostic tool. So here's the differential diagnostic flowchart that we developed for GSD-5 and 7. At the very top, we outline common signs and symptoms. Then we move down to what triggers for symptoms might be, optimal investigations, and then diagnostic testing. The area that is shaded in gray is the most direct route to diagnoses, but you can certainly follow through that as there's quite a bit more information contained here. We begin the overview of management section talking about the benefits of a center of expertise. Ideally, diagnosis and management should be undertaken by an experienced clinical team that works out of a center of excellence, but we understand that is not always available to all patients. We then talk about the benefits of regular assessments, so how frequently patients should be seen and what tests should be done at each visit. We have a section on labs. Of course, we highlight CK and how that value is typically elevated even at baseline for patients with GSD-5 and 7. But we also get into other abnormalities in test results or in lab work that clinicians may be less familiar with. For example, when CK levels are elevated, liver enzymes ALT and AST are almost always elevated as well. And so that, while not a normal finding, can be expected in GSD-5 and 7. And then we have a look at information and guidance for day-to-day management. So we begin with how to achieve second wind. That's a valuable tool for those with GSD-5. We have a section on physical activity that covers both aerobic conditioning and strength training, and that is contained within a supplementary document. We then look at dietary management specific to each GSD 5 and 7. We have a section on cramps and contractures. We talk about the difference between the two and how to manage them. And then lastly, there is a section on pain management. The primary goal, of course, in GSD-5 is to avoid excessive muscle breakdown, and by doing so, the experience of pain should be lessened. So we touch on acute pain and how to management, and then for those who are having to live with chronic pain, we touch on that as well. Next up, we look at a few different medical emergencies that individuals with GSD-5 and 7 are at increased risk for: rhabdomyolysis, acute renal failure, compartment syndrome, and for GSD-7, hemolytic anemia. And then lastly, we have provided a small section on Rehabilitation Protocol. So it talks a little bit about when patients can be safely discharged from the hospital if they were admitted for any of the above conditions. And while there is no scientific evidence at present on how GSD-5 and 7 patients should gradually and safely return to baseline activities, we do provide some very loose guidance on how to achieve that. Because of course, the concern is if patients are recovering from, let's say, rhabdomyolysis and return to their normal activities, they will be more susceptible to a subsequent event if they don't err on the side of caution and take things slowly. So we then move on to general medical care, because of course GSD 5 and 7 does not exist in a vacuum, and over the course of one's lifetime, individuals often do develop other conditions. So we explore how GSD 5 and 7 may impact those conditions, or how those conditions might impact GSD 5 and 7. So we begin with considerations for general practitioners. They certainly have a role in supporting patients and sharing information, whether it be to improve fitness, to limit anaerobic activities, how to use second wind for those with GSD 5, the psychological impact of living with a rare disease, and lastly, recognizing symptom onset and when to seek out emergent care. We then move into more specific areas of focus: cardiology, rheumatology, nephrology, psychology, endocrinology, ophthalmology, and hematology. So there are some conditions such as gout that are well documented in GSD 5, whilst others, such as some retinal disorders, that are emerging. And so we do talk about those in this section, and that is contained in the supplementary material. And then lastly, we highlight potential drug-disease interactions. So for example, statin medications are generally well tolerated, but the most common side effect for everyone, including the general population, is myalgia or muscle pain. And so the recommendation, of course, is to start low and to go slow when prescribing new medications for patients with GSD 5 and 7. And then we do move on to highlight a discussion with regards to malignant hyperthermia and different medications or anesthetic agents that are used. We have a section on surgery. Again, it goes over which medications are safe to use and alternative ones that might be considered by anesthesiologists. And then we have a number of different preventative measures that we highlight, such as monitoring body temperature for malignant hypothermia, putting in a urinary catheter to look for myoglobinuria, avoiding tourniquets or continuous blood pressure monitors, patient positioning, and so forth. The next section is obstetrical care. We do highlight that the uterus is composed of smooth muscle and therefore not directly affected in GSD 5 and 7. That being said, all of the ancillary muscles could be affected, particularly during labor or perhaps when caring for a baby. So we talk about the different stages of pregnancy, delivery, and recovery, and highlight certain considerations for each. We then have a section that we've moved to the supplementary material that outlines a variety of different resources and publications for both clinicians and patients. These are comprised of publications, websites, videos, and different courses that are available to patients. And then lastly, we wrap up with emergent issues and knowledge gaps. So we begin with impact on carriers. So are there symptomatic carriers? We then talk about a study that was done at Brunel University on third wind. That sort of is subsequent to second wind. So other metabolic pathways that might be providing energy to those with GSD 5 as they continue with physical activity beyond the 30-minute mark. We then look at a low-carb ketogenic diet in GSD 5. There are a few studies that are currently underway exploring this, the efficacy and benefits thereof. And then lastly, we wrap up with a section on cognitive impairment in GSD 5 and 7. A number of years ago, there was a pilot study on neuropsychological performances in GSD 5 patients, and it did show that some patients performed worse than unaffected patients on tests of verbal fluency and verbal memory. So further studies certainly are warranted to assess the involvement moving forward. It is our intent to publish these clinical practice guidelines in the journal Neuromuscular Disorders, and we plan to submit in the fall, September, October, depending on when the review team is able to get through everything. And we would like to extend a heartfelt thanks to Reneo Pharmaceuticals. They are currently doing clinical study for GSD5, but they provided a $5,000 donation so that this paper could be published under open access. In other words, everybody will be able to access the paper, download it, read through it, and share it with their clinicians. Thank you to everyone, and certainly if you do have any questions at all moving forward, please feel free to reach out to me, Stacey.Reason@IamGSD.org. Thanks again.